Naufal ada?
Ada.
Oh, Naufal. Cepat. Komen X-ray ni, nampak tak?
Nampak. This is an AP view, X-ray AP view of lower limb.
Okay, it's AP view. What type of AP view, do you know? Tak tahu.
Lower limb.
Yelah, memang lower limb. Apa special? Biasa kita ambil macam panjang macam ni ke untuk X-ray?
Tak.
Ada ke?
Tak. Maksudnya satu.
Biasa ambil one bone, right?
Yes.
What type of X-ray is this? Yeah, it's an AP view, but what type of X-ray? And apa fungsi dia kalau kau tahu? Do you know? This is a long limb X-ray. So what do you think is the reason that we take this type of X-ray?
To differentiate between the two limbs.
Okay, differentiate what? Mainly you want to assess what? Kita nak assess apa biasanya?
Limb line discrepancy.
Okay, lagi? That one boleh buat clinical kan? Do you think in this patient ada limb line discrepancy tak?
Yes.
Ada. Why do you say that?
Because there is difference between the level of knee and also ankle.
Good. Yeah, right. So the level of both of the joints are higher on the left side, right? Yes. Okay. So what do you think this type of X-ray, this limb, long limb X-ray ataupun a scanogram, what do you think is it for? Usually kita guna untuk patient-patient yang ada limb discrepancy lah, pula but LLD kau boleh measure kat luar kan? So what's the reason we do this X-ray? Ada tak? Kita akan tarik buat line daripada sini, bawa ke bawah. What is that?
Mechanical axis.
Oh, good. Okay, so it's a mechanical axis. So this type of X-ray is good for assessment of apa? Alignment, right?
Alignment.
Mechanical axis, all your axis is for alignment punya assessment, right? So comment on the femur. What do you see? Nampak tak? Kau nak besar lagi.
Nampak je.
So this is an AP, this is an AP view of the femur. What do you see?
So there is shortening of the left femur.
Okay, lagi?
Then there is screw at the distal femur. Two screws.
Okay, 2 screws, alright.
And then there is malunion of the distal femur.
Why do you say it's malunion?
Malunion.
Bila aku persoalkan tu tak semestinya kau salah. Why do you say it's malunion?
Because there is no fracture line.
Okay. So you rasa dah united lah.
Dah
United ke belum? How do you define malunion? How do you define malunion, Naufal? Kau tengah rujuk buku ke apa tu? Senyap.
There is disruption from the alignment that not line. They unite but not in a good alignment.
Okay. So the bone is united, however, is not in the appropriate position, right? Okay.
Position, yes.
Okay. All right. So this is you think it's a malunion? Okay. All right. Anything else?
Yeah. Oh, there's also malunion at the left fibula.
Fibula, alright. Itu je, fibula.
Left fibula. And tibia.
Tibia pun ada, tapi aku suruh komen on femur je kan.
Oh, femur je, okay.
Sibuk nak komen tibia.
Okay.
Okay, this is the lateral view.
Lateral view.
Mm.
Also
What do you think the fracture was before? What type of fracture it was before?
fracture.
Itu tak penting, tak apa. What else you want to see when you describe an X-ray? One, you if there is a fracture, you tell ada ketak fracture. This one there is a malunion, so you kata there is a malunion. And then what else you have to tell me whenever you describe an X-ray? Satu, you dah cakap the benda yang abnormal yang you nampak, you dah describe. And then you kata it is malunion. Okay, good. Anything else you want to describe with regards to that? What deformity that you see, right?
What deformity?
You only told me one deformity, which was the shortening, right? You say that there is shortening. Okay, good. Any other deformity that you can see on AP and also lateral? Okay, AP apa? Ada tak? So this description of X-ray holds true for any trauma punya X-ray, okay? This is a complication of trauma. Even fresh trauma, katalah kita tunjuk kau dia punya previous X-ray before waktu dia mula kena apa fracture dulu kan. So and then we want you to describe. So you have to describe the fracture. Okay, first the usual name, view, and then what fracture that you see, ada ke tak fracture, and then what type of fracture that you see, okay, and then the deformity that you can see, right? So in this case, the previous fracture, kalau kau dapat catch lah, kalau kau tengok AP ni, Noval, it is actually a segmental. This is one segment. Okay, this segment yang beralih ke tepi and then was displaced to the lateral and then dia jadi shortening. And then this whole gumpalan united together, so it jadi malunited, right? So what deformity can you see here? Is it the same as this normal femur?
No.
Lain tak? So there is what? There is some angulation. What angulation is this?
Angulation.
Nampak angulation sini kan? Pergi situ sikit. Okay. What angulation is this?
Lateral angle.
Lateral angulation ke? Betul? When you describe angulation, what's your reference?
Reference is the proximal part.
Yeah, ke proximal part? No. When you describe deformities, any deformities, often the reference is the distal part, except for angulation. Angulation, dia punya reference apa? Reference there, the position of your.
Position of.
Okay, katalah this one. Right. Ni ada angulation tak?
Slight angulation.
Angulation mana? Distal ni pergi mana?
Distal tu anteriorly.
Pergi ke depan.
Ke depan.
So macam ni, macam tu. Okay, good. You nampak tu. But is that the proper description of angulation? Is the reference the distal part? No, the reference is not the distal part. What's the reference? The reference is the apex of you punya angulation, right?
Apex angulation.
So kalau macam ni, macam tu, so apex kat mana?
Dekat situ.
Yalah, anterior ke posterior?
Anterior ke posterior?
Macam tu.
Posterior.
Posterior lah.
Posterior.
Kalau anterior dia akan macam tu, betul tak?
Yes.
So this is more posterior. So it is posterior angulation. Kalau this one, it is?
Medial angulation.
Medial angulation, right? So angulation, remember that whenever you describe angulation, the reference should be the apex of the angulation. Okay? Okay, so this is the case of malunion. All right, so dah Noval. So now, so when we are going back to you punya that you will get for exams pro would be usually complications of fracture. Commonly would be union problems lah. So what do you think would be the common complaint in a case of either non-union ataupun malunion, what would be the chief complaint that you should be able to elicit from the patient? Siapa lagi? Kenapa aku tak kenal lah korang? Kenal budak grup aku. Najwa Abdul Razak. Ada ke tak ada?
Ada, Mister.
Okay. Apa tak aku tanya tadi? What would be in the case of malunion ke, non-union ke, what would be the chief complaint that you look for? Or what would be the symptoms that you look for?
So kalau kita tiga non-union, malunion kan. So kalau non-union sebenarnya patient might come with pain. Lepas tu kalau malunion maybe patient boleh datang dengan deformity lah.
Which one? Malunion deformity. Okay, malunion deformity. Non-union? Pain.
Sakit. Pain.
Sakit macam mana? Is it persistent? Is the pain persistent? Sentiasa sakit ke?
Weight bearing lah selalu.
Okay, so it is often associated with weight bearing, right? Pain on weight bearing. If non-union, how about if what's the common non-union that you would encounter? Type of non-union that you would encounter?
The atrophy or hypertrophy tu ke, Mister?
Is okay. Is that a common?
Septic.
Usually septic, right? Okay. So kalau septic, what would be the complaint? Selain daripada pain on weight bearing, yeah, that's true. In any non-union, be it aseptic ataupun septic, patient often will complain of pain on weight bearing or on using that affected limb. Okay. Tapi kalau because a common cause of non-union is actually infection, right? So what additional features that you want to look for in a septic non-union? Najwa.
So patient can datang with infection symptom lah, macam demam, fever.
Okay, but that one usually this a septic non-union, is it an acute type of infection or is it a chronic type of infection?
It's a chronic types of infection.
Usually it's a chronic type of infection, right? So sometimes fever ni semua tu tak ada sangat lah. But what would be a almost pathognomonic feature of septic non-union? Ataupun osteomyelitis, what?
Swelling.
Pathognomonic symptom or sign, symptom lah. Apa?
Swelling, discharge.
Is it swelling?
No.
Tak adalah swelling sangat, but bukan it is sinus discharge, right? Sinus discharge is almost pathognomonic of osteomyelitis, and then if you have a possible complaint that suggests to you that it is non-union plus osteomyelitis with a discharging sinus, so most likely it is a septic non-union lah. Maksudnya the union is because of infection. Okay, the non-union is because of infection, right? So what else? Okay, so another history that you should elicit from this type of patients is the history of dia punya injury lah. Okay, the injury. So okay dah Najwa, thank you. So so when you want to get a history of this this injury, you have to focus. Okay, so ni semua slide ni aku dah pernah tunjuk dah korang nampak kan slide ni kan. Okay, so the history of trauma and the history of what was done for the patient, do you think that we need to focus on the mechanism of injury now? At this moment of time, katalah dia dah pernah kena MVA 5 years ago. having persistent sinus discharge since MVA. So is it pertinent for you to ask about to ask and also present in detail about the mechanism of injury?
No.
Okay, repeat yes. It is not pertinent anymore. Okay, tak perlu. So kau tak payah membazir masa tanya dia naik motor macam mana, U-turn macam mana, kena langgar macam mana, right? So that doesn't hold so much impact with regards to the history. So what is more important is the history of you punya discharge ke, pain tu dah datang sejak bila, right? And then maybe a summary of what was done for the patient, okay? What I observed through many years of handling you punya professional exam in cases of complications of fracture ni, you guys are often lost when you want to present or when you want to clerk about dia punya previous surgical history. Maksudnya dia punya what was done for the injury. Korang akan cerita panjang lebar, korang akan clerk banyak-banyak sangat, right? And then bila korang present pun korang akan jadi lost. So kau akan lost, lecturers akan lost, lepas tu in the end markah pun tak dapat. Okay, so you do not need to describe in very detail what was done, bila was done dan sebagainya. No need. You just give a summary. Contoh katalah macam you had let me give you an example of a patient that we've done. Okay, so this is a old patient yang kita pernah nampak ni, nampak kan? So this patient had a history of motor vehicle accident about 5 years ago, in which he sustained an open fracture of a tibia, and then was complicated. Was managed accordingly with external fix and then followed by internal fix. However, was complicated with persistent sinus discharge following insertion of internal fix. Right. Since the presence of that sinus discharge, they had removed the internal fix and then changed to a type of Elizarov for a few years to manage the problem. However, the problem still persists. Now he's coming with complaint of pain whenever he walks, with still persistent discharge now coming out, frank pus coming out from the sinus wound at the anteromedial aspect of the punya leg. Okay. So nampak tak? That's the summary that I gave. Okay. So you just need to give it like that lah. So this what is important from the mechanism of injury during the first MVA is at least you get was it an open fracture or was it a closed fracture? Okay. So then you determine that. So like this case, this was an open fracture 4 years ago, which was treated accordingly with external fix followed by internal fix. That's the usual thing that we do, kan? Untuk any open fracture, right? Yeah, we fix temporarily with external fix. Once no signs of infection, then we change into internal fix. And then like this case, and then following the internal fix, he had a problem of persistent discharge. Ataupun persistent discharge and features of infection like swelling, erythema dan sebagainya. So that shows that after we put in the internal fix, there was a complication of what? Infection, right? The implant related infection. Okay, so and then there was persistent discharge, so we had to remove because of that. So we decided that the internal fixation was removed and then changed to external fix, Elizarov external fix, for multiple years. However, the problem persists. Now it is actually becoming worse. So cukup. You don't have to ask how many times dia pergi masuk OT untuk pasang Elizarov ke, tukar Elizarov ke, tukar kepada LRS ke, mana ke, no need. Okay, understand? Faham tak?
Faham, Doktor.
Mau senyap ni, susah kalau online ni. Tak nak tengok muka. Tapi kalau buat face to face ramai sangat, kan? Okay, so that's the concise history that you need. So usually for me, you focus first on what is the chief complaint, right? Focus first on what is the chief complaint for that patient or for the current admission, for the latest admission now. Okay, so katalah patient datang for exam, bila kau clerk, often patient akan cakap apa you akan tanya why did you, kenapa datang ke hospital hari ni, betul tak? And then dia akan jawab datang untuk exam. Kan? So bila kau present patient complain or came to hospital for exams. Janganlah gitu. So for you to be more cerdik sikit, bila dia jawab macam tu kau cakap lah, okay ya saya faham datang for exam, tapi apa yang menyebabkan cik datang ke hospital yang terbaru? Yang paling latest ni, yang terbaru, apa encik datang ke hospital ni kenapa? Apa masalah? Dan baru dia akan cerita apa problem yang, latest problem yang dia ada. Okay? So like in this patient, his latest problem was persistent past discharge from dia punya leg. So when you get this type of history, that would be your chief complaint. Okay, so you focus on the chief complaint first. So your chief complaint in this case would be past discharge from the anteromedial leg wound. So you cerita dah berapa lama, apa nama, what type of discharge, okay, associated with pain or not, ada tak dia punya what makes it worse, what reduces it, ada tak features of infection, okay. Focus on the chief complaint first. And then barulah kau cerita pasal dia punya previous problem yang mungkin berkait dengan dia problem sekarang ni, macam yang aku buat summary tadi. Okay, understand? So janganlah start terus this patient just bagi tahu complain dia sikit, complain of discharge, and then now 5 years ago patient had a history of MVA. Jangan terus lompat gitu. Cerita pasal dia punya current complaint dulu. And then baru kau cerita pasal dia punya previous history. Okay, understand? And try not to be lost lah, because korang tahu what is the usual management for fractures. So you should be able to do that. Okay. Alright. So let me see. So okay, Nur Aina.
Yeah, Prof.
Cepat.
So this is an X-ray of femur. And in AP position, the right femur, there is
dia ke AP, tak boleh nak tahu AP sebenarnya, but this is not AP lah sebenarnya. Kalau kooperatif betul, this is not AP, this is lateral, right?
lateral.
Mana ada AP kau nampak macam ni?
Okay, sorry.
This is your distal, tapi tak apa sebab kau tak nampak dia punya knee. If you see the knee properly, this is not AP, okay? But anyway, so what do you see?
So there is
Ada apa?
Involucrum.
Apa benda involucrum?
ada encasement of the dead bone.
Okay, dead bone, okay. Where's the dead bone?
Dead bone is sequestrum.
Okay, which one? This one?
Yang dalam.
Dalam, this one? Okay, so this is a sequestrum. What was it, a sequestrum?
The dead bone.
Dead bone, alright. Involucrum mana?
Yang sekeliling dia. The encase.
Keliling. This one? Ke yang hitam?
Yang border lepas hitam.
Ni yang putih ni? So what's involucrum?
Involucrum is reactive bone, new bone formation.
Okay, new bone formation, that is a reaction of the living bone towards dead bone. Okay, so the living bone punya reaction towards a dead bone would be formation of this involucrum. Okay, formation of new bone. Okay, fine, good. So what's yang hitam tengah ni apa? Hitam ni. Discharge. Apa kandungan dalam ni? Is there anything within here?
Pus.
Okay, usually it's pus. It's an empty space, okay, because your healthy bone will never be able to incorporate ataupun resorb your dead bone, okay? So it will encapsulate it and then form an area there will be an empty space between the living bone and dead bone. So that empty space usually is filled up with pus or fluid dan sebagainya lah, right? So this is what we call the halo sign. Okay, so Rifdi tadi jawab pasal cloaca. This is not cloaca. What is the cloaca? When does the what is the cloaca? Do you know? If this is left for nothing is done for it, later they can form cloaca, right? Cloaca is basically when part of you punya involucrum ni dia pecah. So it will form here. Okay, so basically it will break through your pus will break through your involucrum and then it will go outside. So this cloaca, once it breaks through your involucrum, it forms that cloaca at the bone, and then they can form a sinus, and then it will go out, and then it will discharge. Okay, because the body is trying to remove the sequestrum. So mula dia kumpul, dia encapsulate, once tak boleh nak buat, dia akan pecah. Macam bisul lah, dia akan pecah through forming a cloaca and then trying to remove it by pecah-pecahkan sikit the sequestrum, dia jadi small pieces and then expulsion, buang through your sinus. Okay, but if the sequestrum is too big, it is difficult to happen. So then we have to help to remove it ourselves. Okay. So this is a classical X-ray feature of chronic osteomyelitis, presence of sequestrum, involucrum, and also the halo sign. Okay, kalau dia lagi advanced, dia akan ada cloaca and then presence of sinus, right? So this is just showing you classic chronic osteomyelitis, right? What is this? Apa aku tulis ni? Classification. Korang tahu kan classification of OM? Can anyone tell me classification of OM? Farah, okay, Farah. Cyani matter Which states? Okay, katalah this is the patient. Kau pernah tengok dah kan ni kan, Farah?
Dah.
Okay, so how would you classify this patient? This is a patient come to you with protruding bone macam tu, right? 60-year-old diabetic. Give me the classification. Most likely ada OM, right? Most likely ada OM. So what would be the classification of dia punya OM? Oh, sorry.
Since patient is diabetic, so patient for physiological class, jadi compromise locally or systemically, so class B.
Okay.
For anatomic
So dia
type,
B lah.
B,
B,
class
alright, B. So dia compromise systemic ke locally?
Systemic. Both.
Local tak ada?
Local dua.
Kenapa ada local compromise? Yang lain dengar tahu tak
Ada
ni?
infection.
Memanglah semua ada infection, osteomyelitis. How do you say it's locally compromised?
Multiple scar, hypopigmentation.
Why multiple scar is considered local compromise?
Previous surgery.
Macam mana Sambah? Sambah je lah.
Kalau scar tu possible ada previous surgery to that location.
Okay, yeah, alright. It can be previous
Because
surgery.
fibrosis lead to reduce in
Apa, Aina?
fibrosis lead to reduce vascularity.
Okay, alright, yeah. So, yeah, Sambah cakap there was a previous surgery. Memang lah, hence mestilah because of that lah you dapat scar. But that doesn't answer the question. How does the scar causes local compromise? So what Aina jawab is correct. So when you have scars, the skin tu dia dah jadi abnormal. Dia dah bukan jadi normal skin tissue. Dia dah jadi fibrosis. So when you have fibrosis, the vascularity is reduced. The capability of the fibrotic skin to heal becomes much less. All right. So that compromises it locally. So this patient there are two compromise systemic because of the diabetic and also local because of the multiple scars yang ada around the affected area. Okay. So Farah, balik pada kau. So this is the X-ray. So how would you classify it anatomically?
So
Farah?
from this X-ray, I think the whole cortex is involved.
Hmm.
So this should be diffuse osteomyelitis.
Okay, so this is
Stage four.
diffuse osteomyelitis. So it is diffuse host type B, L and S, maksudnya systemic and local, with the anatomical classification of diffuse, all right? Because the whole multiple cortices are involved, all right? And it is very, very unstable. Basically, if you have non-union with infection, definitely there is a component of osteomyelitis going on. Betul tak? If you have infection around the bone. So, and then you are the non-union. So definitely lah, it is a diffuse because non-union maksudnya the whole bone, the multiple cortex are involved. Betul tak? Right? So, kalau macam yang ni, is this diffuse? Farah, kalau yang ni, is it diffuse ke local?
Ni local.
Okay, this is mainly local because a single cortex is involved, and then even if we remove it, the bone is still stable. Okay, so the major difference between you ada 4 classification kan untuk anatomy: medullary, you ada you ada medullary, superficial, localized dengan diffuse. So medullary tu just within the medulla. Superficial is just the outer 1/3 of you punya bone. Often in cases like diabetic foot ulcer ke apa ke, you get a superficial type of infection, osteomyelitis. Localized is either a single cortex, and also if you remove the affected bone, the whole bone is still stable. That is for localized. But for diffuse, it is multiple cortex. And if you treat the osteomyelitis, you remove the osteomyelitic bone, the bone becomes unstable. Already unstable even from the first go pun dah unstable. Okay, so the main difference between localized and diffuse are the number of cortices involved and also the stability of the bone that is infected. All right? Okay, understand? Okay, so apa soalan aku tadi? Okay, tak apa. So tadi Naufal define malunion kan? Anyone want to define non-union? Non-union? Sekejap. Bagi aku seru ya. Siapa nak seru? Orang-orang yang aku tak kenal. Berapa orang Aina ada dalam grup kau ni? 3 orang Aina Najla. Oh, Najla. Najla Harun Ada? Tak ada ni.
Ada, Prof.
Kau pergi mana? Toilet Okay. So how do you define non-union?
So basically, non-union ni is a fracture yang does not heal lagi.
Itu je kau punya definition.
So usually,
Fracture that not heal. Okay.
not unite without any intervention lah.
Okay, so fracture that has not gone into union and will not unite without intervention. Okay, yang second part tu betul. The first part tu dia kurang lengkap. Fracture that has not united, what? Within
6 months.
Within 6 months, within the expected time lah. So how long do you expect a fracture to unite? How would you define it? 6 bulan ke? 9 bulan ke? 11 bulan ke?
Within 6 months.
6 months. Okay. partially correct, but the agreement is actually 9 months. Okay, we take 9 months. However, you can still consider 6 months if during your assessment at 6 months too, there are no signs of union going on. Maksudnya there are no signs of callus at all. So katalah when you follow up patient at 6 months, you tengok fracture tu tak ada langsung callus yang form. When you expect callus lah. So callus tu tak form langsung. So at that moment of time, you can say that it is already non-union. However, katalah at 6 months, callus tu ada, tapi belum complete untuk kata the union. So then you cannot say it's non-union yet. You still have to wait another 3 months. Wait until 9 months to see ada tak union. So saying that, how do you know that fracture is united or not? Najla, again, how do you know? Tadi you define non-union. So how do you define union pula? Najla. Oh, Najla.
Yeah, Mister. So basically, to look for the union, we look the formation of the bridging callus at the cortical dekat cortex tu. So,
okay, what do you mean? What do you mean by bridging callus?
So is for us to call it as union, it should be there is presence of callus more than 3.
More than 3 apa?
Of the cortex.
Okay. Kalau aku bagi kau ni, kau baca nota ke apa? Kau ingat?
Ingat lupa.
Ingat lupa. So this one unite atau tak? Oh, Najla. Nampak tak?
Nampak.
Unite atau tak? Callus ada? Ada kan callus? So unite atau tak?
This one, so this one I think we should, yang belah kanan, yang belah kiri ni AP ya, Mr.
This one is AP. Agak-agak, janganlah tanya aku. What do you think? Is this AP ke lateral?
So AP.
Why do you say it's AP? Boleh tanya aku. Why do you say this is AP? Why you say this is lateral? Ini tak boleh, dia tak ada alasan ni. Ini memang perlu tahu. This is AP atau lateral. Yang gambar tadi, yes. Sebab tak nampak lengkap. This one nampak lah. You should know is AP or lateral.
Basically, kita
lateral.
nampak 2 joint.
Okay, yeah, you should see 2 joints, yes. But now you can see 1 joint. So is that joint AP or lateral now? In this one?
From the anatomically, I think it is an AP lah, AP view.
Kau nampak macam ni kan? When you see the knee joint macam ni, you can see the tibial plateau nicely, you can see the tibial spine nicely, so it's AP lah. This is a lateral. You should know how does the knee joint look like on AP and lateral, okay? So this is AP, right? Okay, so now, is this united or not?
I think from the AP view tu nampak united.
This one, united, okay.
And lateral.
InsyaAllah united with you. InsyaAllah united, okay. On lateral? United lah?
On lateral aspect also united.
United. So just now you said your definition of union is presence of bridging callus 3 out of 4 cortices. Kan?
Yes.
Betul tak?
Betul.
Therefore, daripada kau punya description of that and seeing your jawapan untuk this type of this X-ray, it seems that you do not understand what you are trying to say. Betul tak? Because this is not united. Macam Murad jawab, this is a hypertrophic non-union. What does it mean? You have formation of callus. However, there is no bridging callus. What do you mean by bridging callus? What does bridging callus mean? Is simply you see callus that goes across the fracture line. So when you see here, there is no callus going across this fracture line. So what we mean by the cortices are, when you see AP and lateral, there will be a a combination of 4 cortices. This is one cortex, which is a lateral cortex. This is your medial cortex. This is your anterior cortex. This is your posterior cortex. So if when you see a total of 3 out of 4 cortices tu ada bridging callus, then that is united. In this case, yang ni definitely tak ada. Alright, on AP. This one maybe ada, maybe tak ada. Dimaafkan kalau kau rasa ada. Okay. This one memang tak ada. This one memang tak ada. There is no connection between the edges of you punya fracture line. Betul tak? Dekat dia punya cortex kat sini. Betul tak Najla?
Betul. Apa
Apa dia?
betul.
Apa yang kau nak cakap? Oh Najla.
Ya,
Apa yang kau nak cakap tadi?
tak, saya mengiyakan Mr. punya.
Okay. So this one tak nampak ada bridging callus. This one tak nampak ada bridging callus. This one memang langsung tak ada because ada lekuk lagi. This one maybe ada atau tak ada tapi dimaafkan kalau kau rasa ada. Okay. Mungkin ada. However, kalau this one ada pun it's just one cortex, right? So it's definitely not united yet. So you need 3 out of 4 cortices here ada bridging callus baru kau kata it is united. This is a type of aseptic non-union and it is type of hypertrophic non-union. Okay? Pernah dengar hypertrophic non-union?
Nah,
Okay, tak?
Nah,
Okay. So what's the problem with hypertrophic non-union? Alang-alang kita dah hadir kat hypertrophic non-union ni. Sekejap aku tanya orang lain je. Siapa? Apa Rifdi?
in hypertrophic non-union, the blood supply is okay, but there is a lot of movement of the.
Okay, yeah, movement and also it is not basically the fracture is unstable. Okay, there is not enough stability at the fracture site to allow bridging callus. Basically, callus tries to bridge. That's why they form callus. Tak ada masalah, boleh. But every time it tries to bridge over, the fracture moves. So when the fracture moves, the bridging callus tu pecah semula. So they try to bina and then pecah, try to bina and then pecah. So that's why they develop this type of elephant foot type of feature that you see here. Dia besar tapi it doesn't goes across. So this is a hypertrophic non-union, the problem of unstable fracture. So how do you manage? You
Stable.
make the fracture stable back lah. So how you can put an implant ataupun you can change to a better type of fixation. So once the fracture is stable, then the bridging callus can occur, right? Okay, so let me show you. Where is it? Apa ni? Then, okay, so this is the explanation of yang aku cakap tadi. So in this tibia, this is when you say it is union, right? So if you see closely this picture, this one, you can see the fracture line still, right? This is the fracture line. This is the fracture line. However, you can see there is bridging callus across your medial cortex, your lateral cortex, your posterior cortex, maybe not so much at the anterior cortex. But all the other 3 cortices, okay, this one, you can see that there is bridging callus. If you see closely, dia ada macam bone going across, okay? So that is what we call bridging callus. So in this case, it is considered union. Okay, the fracture has already united, okay? When you go to this side, this one, there is no more fracture line. Dia ada sikit dekat depan ni. So this one dah considered consolidated. Okay. So when you want to see union, this is what you want to see first, bridging callus. The fracture line may still be present, but bridging callus tu ada, so it's considered union. So janganlah bila aku tanya how do you know it is united or not? Fracture line tak ada. Fracture line tak ada is when the fracture has consolidated. Okay. Okay, Najla, faham
Mister. Thank you.
Alright. So this is another form of severe type of hypertrophic non-union. Maksudnya dia pernah ada hypertrophic non-union dulu, and then because dibiarkan lama, and then it forms. What do you think this is? If you have hypertrophic non-union and then it is left for a prolonged period of time, years, you will develop this. What is this? Anyone knows? Siapa jawab ni? Shafika or Shome? Yes, betul. This is a pseudoarthrosis. Okay, so it was a form of hypertrophic non-union, but because it was left for a prolonged period of time, so it develops, it becomes a pseudoarthrosis. So basically, dia memang ada dia punya own cartilage dalam ni, dia ada dia punya own synovial fluid. So in these cases yang dah lama, you cannot simply just go in and change into a stable, a more stable type of internal fix. It's not enough because dia dah ada form dia punya own joint, so we have to go in and we have to remove that pseudoarthrosis, that pseudo joint, the cartilage, the synovial fluid kena buang, so kita kena reset lah, and then baru kita buah internal fix. Okay, but this one often bila dah lama sangat. Alright, okay, so how about this? So kita dah termasuk ke gambar ni. Sekejap, panggil siapa? Panggil ni lah, panggil jantan pula, Zakwan. Oh, Zakwan, Muhammad Nur Zakwan bin Rizal.
Ya, Mister.
Ada.
Ada.
Okay. Ni United atau tak?
This is non-union.
Okay, non-union, alright. What type of non-union?
This is atrophic non-union.
Why?
Because there's lack of callus formation, as
Okay.
well as there's no bridging of the callus.
Lack of callus, betul. No bridging of callus just simply defines non-union.
Oh yes.
What else which would indicate that it is an atrophic non-union? One, tak ada callus, okay. Tapi tak ada callus boleh jadi oligotrophic juga. But this is more atrophic. Why do you say it's atrophic? What does atrophic mean? Atrophy, what does it mean?
Atrophy means there will be atrophy mean lack of size lah, meaning there is a tapering.
Okay, betul, bagus. So atrophy maksudnya there is a reduced size compared to the normal size of that tissue, right? Betul tak?
Yes.
So what do you think? Cuba kau tengok size atas ni
Yeah.
dengan
the
bawah
size,
ni.
Yeah, the circumference of the proximal part is wider compared to the distal
This-
part.
So dekat fracture site ni nampak kecil kan?
Mm-mm.
When you see the distal, even the distal part is smaller compared to this one, right? It should be one line kan? Daripada
Yes.
atas ni ke bawah one line. Sampai sini dia mengecil. What do we call that?
Tapering, penciling.
Aiman kata tapered. It's a penciling, okay? It's a penciling of you punya fracture, okay? You see penciling at the fracture site, fracture edges. So why does this happen?
This is maybe due to lack of blood supply or nutrient to the
Okay.
fragment side.
Usually because of lack of blood supply, right? Either because of the fracture itself ataupun stripping of you punya periosteum at the fracture site. Okay, so how do you treat this?
So we have to provide nutrient with maybe bone graft.
Okay, so you
as
put
well as
bone
the
graft.
maintain stability.
So internal fix with bone graft. Some sort of fixation with bone graft lah. Stability provided by fixation and then bone graft. Is that enough? So basically kau bubuh maybe an Ilizarov ke ataupun a nail ke and then sumbat bone graft. Is that what you mean? It's partially correct, but do you think it's enough?
We have to remove the atrophic bone first.
Okay, because this bone macam kawan-kawan kau jawab kan, excess sclerotic bone debrided. Yes, because this bone is already abnormal. Kau sendiri cakap tadi the blood supply dah reduce kan? Is already reduced, menyebabkan dia jadi atrophy, right? So this bone is already abnormal. So if you just put a internal fix ataupun external fix and a sumbat bone graft, its capability to heal is not as good lah, kan? So we have to resect the affected bone. The damaged bone tu kau kena buang sampai you dapat healthy bone. So once you dapat healthy bone, then okay, kau bubuh some sort of fixation, and then you can put bone graft there. But it has to be healthy bone lah. Okay? Understand, Zakwan?
Understand.
Alright. Okay, good. So now we go back to septic non-union tadi. So how do you manage septic non-union? So you get a history of non-union with discharge, and then you see X-ray tadi. Memang you classify it as diffuse. So how do you manage septic non-union? Sekejap. Siapa yang bukan group aku? So aku tak ingat lah siapa group aku. Darwish. Darwish ada Darwish?
Ada.
Ada? Okay.
Septic non-union.
Bagi principle dia. How do you manage? What should you do first?
So first we treat the infection first. So we give systemic antibiotic first. So after that we plan for debridement, bone debridement.
So you bagi antibiotic first ke you debride first? Which one?
If patient is in sepsis or unstable, so we stabilize patient first, and then we need to aim for adequate debridement.
Oh, memang tak menjawab soalan aku tanya. So would you give antibiotic first or you do debridement first? Which one is which? Kau nak buat mana dulu? Okay. You cakap tadi kalau patient tu in sepsis, unstable, is that the majority clinical feature that you will get with septic non-union?
No. So
because it's a chronic problem kan, Darwish? It's a chronic problem. Dah bertahun-tahun benda tu ada, and it is a very subacute type of very chronic type of infection. So it's not very severe. Yes, if the patient kebetulan datang with very bad septicemia, septic shock, sepsis, then you give antibiotics first because you are giving antibiotics to treat the sepsis. But if the patient comes with a chronic osteomyelitis with septic non-union, not that much systemic features, very stable, we do not give antibiotics first. Why we should not give antibiotics first in a stable patient?
Because we need to debride first.
Why should we debride first in this case? If the patient is stable. Kenapa kita tak boleh bagi antibiotik? Korang kan biasa kalau infectionnya terus antibiotik. Every time tanya, whenever you have a diagnosis of infection, what's your treatment? Antibiotics. Terus. Apa dia, Darwish?
Because we need to take culture and sensitivity, and then if we give systemic antibiotic, it will not penetrate if there is any infection at the bone.
Okay.
So we need to remove the cause of infection first.
Alright, okay. So the jawapan kau partially correct, separuh-separuh gitu. So the reason that we should not give antibiotic first in a case in which patient is stable, not in sepsis dan sebagainya, because if we give antibiotic first and then we do debridement, when we take the tissue to send it for culture and sensitivity, dia akan jadi negatif. Because bila kau buat debridement, biasanya in a case of septic non-union, there will be a presence of dead bone, so there will be presence of biofilm dan sebagainya. Tapi bila kau kau usik-usik, kau debride, kau pecahkan biofilm tu, so it will be a wash with antibiotics, kan? So bila antibiotics tu datang, and then everything yang organism yang ada situ semua dah mati. So by the time you hantar for culture sensitivity, it will come back as negative, no growth. So you will not be able to get the true culture lah, the true organism. So we debride first, properly debride, and take a deep tissue sample. The moment kita habis debridement, after we send the patient to the ward, then you can start broad spectrum antibiotics. Okay? You can start broad spectrum. And then after 3 days, once you get back the culture, then you do the specific antibiotics. So in cases like this, betul macam Darwish cakap, the first thing that there are how many problems in cases of septic non-union? Berapa masalah utama yang patient ni ada? Darwish. Satu is infection, second is
to achieve union.
yes, union. So you ada infection dengan you ada union. So first you have to address the infection first. So you start off with debridement, and then you give antibiotics. Okay, so antibiotics, how many methods of antibiotic delivery that we should provide to this patient? One is systemic, lagi?
Another one is local antibiotic.
What do you mean local?
Antibiotic beads.
Okay, so you can you can put the antibiotic impregnated cement ataupun antibiotic beads dekat the area then you debride tadi tu. Okay? Because it will increase the local concentration of antibiotics there, and then it will prevent any new organism to come in. Okay, so you've done the debridement, you've given the antibiotics, systemic and local, and then what's the next step? What, to debridement to itself? Debride, sumbat dengan bone graft, sumbat dengan antibiotic beads, lepas tu?
Stabilize the fracture.
Yes, good. You have to have some sort of stabilizing. What type of fracture stabilization would you opt for? Darwish, kau nak taruh apa?
External fixation.
Kenapa tak bubuh internal fix? Kenapa bubuh external fix?
To see the response if there is any still any infection.
To see the response. Maksud kau?
Sebab
Tak sure.
Anyone want to help, Darwish?
Sebab the infection
Apa dia?
tambah.
Tak dengar?
No.
Ah,
Sebab infection still going on. Kalau letak internal fix, nanti infected dia punya internal fix.
bukanlah infected internal fix, because you even experienced surgeon pun, they will never know that you have removed enough. Betul tak? When you debride tu, we never know that we have removed enough. Okay, so the infection has not settled yet. We cannot put internal fix terus. So you put a form of external fix, because the risk of infection spreading or coming in again much less with external fix. Okay, so because of after kau dah debride, give antibiotics, stabilize, what will be the next step? Siapa ni? Anis Nasuha. Second look. Zakwan kata second look. Anis Nasuha aku kata apa? Anis Nasuha ni ada ke tak ada? Ada ke tak ada? Baik ngaku. Tak ada ni. Okay. Ishak. Muhammad Ishak.
Yes, Mister.
Apa soalan aku tadi?
Lepas XFIT tu nak buat apa?
Okay. So kau dah bubur, kau dah stabilize, you dah debride, dah bagi antibiotik, you dah stabilize, then the next step?
We need to monitor for at least 6 weeks.
Bagus. Monitor. How do you monitor?
So we monitor based on clinical and blood investigation. So for clinical, we monitor sign of inflammation or any discharge.
Sign of infection, right?
Yes.
Signs and symptoms of infection. Lepas tu?
And then for the blood investigation, we can do a full blood count to look for white cell count, and then inflammatory markers such as ESR and CRP.
Okay, jarang kita guna white cell count because white cell count is more for active type of ataupun acute type of infection. So a chronic type of infection ataupun a subacute type of infection, low grade type of infection, we use ESR and CRP, okay? Jarang kita follow up, we do FBC. So you have to follow up for how long at least?
6 weeks.
Okay, minimum of 6 weeks, right? So once everything is normal, clinically is normal, and then blood investigations are normal, then only you go into management of you punya
non-union.
Non-union. Okay, so we go back. So just now the management of infection, first identification of the problem, maksudnya identifying yang you ada non-union plus infection or septic non-union by clinical assessment and also classifying using you punya scanning method. So once you dah identify and confirm that it is a septic non-union, then you do debridement. And then debridement, you stabilize and then you put in local antibiotics and also systemic antibiotics. So once that's done, the next step will be monitoring. After you monitor, then you do your union. So balik semula pada Ishak tadi, so how do you manage your union pula? In a septic non-union, what will it be dependent on?
Yeah, depends on the size gap of the non-union.
Okay, good. It depends on the how much bone that we have removed at that moment of time. Okay, so what type of management have you seen? Ishak, dekat Sasmat, dekat UIA, how do Prof Nazri and myself manage a septic non-union, the union part? What do we do?
So first, it depends on size. So if it less than 2 or 3, we can do a bone graft plus internal fixation.
Okay.
And then if more than 2 or 3, we do Elizarov bone transport.
Okay, right, good. So usually we take 3, Ishak. More or less than 3, we can put bone graft. More than 3, we have to think about bone transport. Okay, so a type of bone transport is it is out of bone transport. Okay, I hope you guys know lah apa bone transport. Tahu kot. Biasa yang canggih-canggih ni korang tahu. Yang kurang canggih korang tak tahu kan. Okay, sekejap okay, so this is an example of a case that we've done. Mana dia? Okay. Okay, nampak ni case tadi yang aku tunjuk tadi. Yang aku bagi summary tadi tu. Alright, so this was the initial problem. So this whole area is infected. If you see closely, this is the sequestrum. These are all dead bone. Dia dah ada lytic lesion dan sebagainya. So this whole length ni dah infected. Okay, so what we had to do is we had to do a debridement. Okay, very big debridement. We had to remove almost, I think, like 10 centimeters, 10 or 15 centimeters. Okay, and then what you see here, the small beads ni are your antibiotic impregnated beads. Okay, and then we put on an Elizarov as a form of stabilizing form. Okay, so this X-ray was taken after 6 weeks of the punya management. So after that 6 weeks, we've determined that this condition is already fine. There is no more signs and symptoms of infection, and the blood investigation seems to be well. And then we went in and proceeded with the bone transport. So what we did is we cut here first. So this is your osteotomy site. We purposely fractured here, and then we transport this piece slowly distally. Okay. So this is the initial transport. Okay. and then this kita transport lagi sikit, and then this is the longest that we achieve at this moment of time. Okay, so this is the new callus that the corticotomy site which we stretched up, what we call the regenerative site. So this is the gap that is left, around 7 to 6 centimeter lagi perlu. However, at this moment of time, patient ni dah tak sanggup pakai Elizarov, and he requested for us to remove it. So that's one of the downside of putting patient on Elizarov. It is very bulky and it is quite heavy. So some patient cannot tolerate for a prolonged period of time. So we had to remove it because patient insisted. So we changed into, because there is still a large gap here, around 6 to 7 centimeters. So we had to change into this. What is this? Anyone knows?
Bone grafting.
Tahu tak? Rifdi tahu tak Rifdi apa ni? Siapa ni? Syam eh? Okay, kau dah pernah tengok ni kan Syam?
Yeah.
Okay, so this is your vascularized fibula graft. Okay, so this is, we took the fibula from the other leg with its own blood supply and then brought it to this leg and then sambung kepada the local blood supply. So this one we had to have the help with plastic surgeon, Mr. Azim datang tolong. Kita orang potong this bone, and then dia ambil dia punya blood vessel, bawa ke sini, and then dia sambungkan kepada blood vessel sini. So this is another form of managing a non-union with a very large gap. But there is risk lah. When we do this, the patient has to be quite healthy and the local blood supply should be good. However, unfortunately for him, that did not happen. The local blood supply is apparently not that good. Initially nampak macam okay. After a few weeks, it became not good. So the vascularized tubular graft becomes what? It becomes non-vascularized. So it becomes, kalau bone tu dah tak ada vessel, what does it become? Dia jadi apa? Nampak tak macam cabang-cabang gini, macam spiky kan? Dia dah tak nampak smooth. Dia dah jadi dead bone lah. So what do you call dead bone?
Sequestrum.
Dia dah jadi sequestrum. So the vascularized fibula graft dah jadi sequestrum. So it's infected. So what can we keep it? Definitely not. We have to remove it. So we had to do another debridement, remove that sequestered vascularized fibula graft, and then buat balik bone transport. So we did a fresh new osteotomy here. Kat atas ni potong, and then transported. So this one we transport sikit. Then this one dah transport the maximum that can, because sekarang ni this gap dah jadi kecil, right? So tapi actually dia ada a bit of shortening dalam 2 cm lagi lah. So this is the latest one. So there is contact here, but now we are planning to put external fix for him, some sort of internal fix for him, right? So we managed to bring it close, but overall because of multiple surgeries done dan sebagainya, so there is a bit of shortening there, and the soft tissue is not that cantik lah. So we hope that this fracture will unite. So this is an example of what we have done for septic non-union. Okay, so setuju kot untuk septic non-union dan non-union per se. So malunion. Okay, any questions on non-union first? Your atrophic non-union, your aseptic non-union dengan septic non-union. The common case of septic non-union will be there lah, during your exams. Okay. Now, malunion, there might be, but the management of malunion, ada kita orang ajar tak? Tak ada kan?
Tak ada.
I think the management of malunion is not so much your level. It's a bit more complex because ada calculation lah, apalah. But identifying it, yes. Maksudnya if we give you an X-ray, and then you have to know how to comment on that X-ray lah, or what type of deformity that you see dan sebagainya. But cases of malunion, not so much, right? But just one thing that I want to ask, if patient comes with a malunion, siapa yang jawab tadi, you nampak one deformity. What are the symptoms will the patient complain? Will there be pain in a case of malunion? Fracture tu dah unite, tapi dia unite in a abnormal position. Will there be pain? Anyone? Murad kata no, but limited ROM. Okay, limited ROM. Okay, yeah, there might be limited ROM, but there might still be pain. Why do you think there is pain?
Masa pain tu sebab dia nak stabilize yang malunion tu.
That one is non-union, Farah. The muscle fatigue that the patient experience is a form of pain that they have to stabilize the non-union bone. If the bone tu dah united tapi mal-united, the bone is stable already. Dia tak perlu nak stabilize. Okay, siapa ni? Aisyah. Okay, Nick Aisyah jawab, joint above and below to decompensate. Bukan decompensate. Yeah, betul. But it is usually the patient complains of pain at the joint above or below because they want to compensate for the deformity yang berlaku. Bukanlah compensate, is more of because this deformity causes abnormal biomechanics of the limb, the lower limb, which is affected. So it will cause abnormal positioning of the joint above and below. So it will cause pain at the joint above and below. All right. So not at the fracture site, but more at the joint above and below. Okay. So that's another symptom that the patient will complain. All right. So I think management tak sangat kot. Malunion a bit complex. Kau kena tahu berapa degree lah, normal ni lah dan sebagainya, and what to do. Okay. Any questions with regards to this? Okay. Cover dah kot non-union. InsyaAllah okay. Senang je non-union. Nampak boleh jawab. Tak tahu lah yang senyap-senyap ni, tak tahu boleh jawab tak. Tak Samba?
InsyaAllah boleh.
InsyaAllah boleh. Okay, one more thing yang Zaim minta was TB spine kan. Tapi TB spine kenapa korang ada dengar pasal TB spine kan masuk exam?
Sebab before this ada yang keluar spine TB.
Okay.
Tahun ni masuk ke Mister?
Tak masuk.
Direct gila.
Masuk lah tu.
Masuk ke? Tak tahu lah sebab satu, aku bukan cari case spine. So tak boleh nak komen lah. Right. Tapi yang keduanya, dulu banyak sangat kecundang dengan TB spine. Tapi ada orang yang kata susah sangat. Tapi ada orang yang kata memang patut korang tahu. So, aku pun tak tahu sama ada akan masuk atau tak. But anyway, kalau TB, kalau spine, spine infection lah, right? Spine infection, aku tak ada slide lah. Just a discussion. So, spine infection, basically ada dua je kan? Either
pyogenic atau TB.
Pyogenic atau TB, alright? So, it is a spine infection is a differential when the patient comes to you with complaint of back pain, alright? And you shouldn't put it as a first lah. Usually kalau patient comes to you, bila kau kelak kenapa datang ke hospital, kata because of sakit belakang. So you kena tailor dulu lah what is more common first, and then you start to rule out. What will be the common complaint of, what is the common diagnosis of back pain? It is often based on age. Kalau younger back pain, be apa? Mechanical ataupun PID, stroke HNP. Kalau older, 40 years old ataupun 50 years old, will be more of degenerative spine, spondylosis. Aku pun tak ingat. Spondylosis. Aku panggil degenerative spine. Right. So that is the more common reason. But you also have to rule out other features. One of the other differential diagnosis of back pain will be infection. So how do you want to differentiate? Is it pyogenic infection or TB spine? What is the difference? The main difference if you suspect it is a form of infection? Do you know? Usually korang akan cakap TB ada exposure to TB lah, ada night sweats. Night sweats is okay. That is a good feature for you to rule out night sweats. Okay. Exposure to TB, if the patient knows, okay lah. But majority patient tak tahu pun. Betul tak?
The
location will be where? Kalau TB kat mana?
TB usually dekat thorax. Dia akan ada hyposis yang extreme tu. Apa nama tu?
Itu gibbous. Itu very bad. Itu yang dah neglected punya type of TB.
Okay.
But how can it be so bad that dia dapat gibbous? Apa ciri tu?
When dia ada destruction at the anterior.
No, you don't understand my question. Okay, if you have a pyogenic infection dengan a TB infection, sometimes if it is the one that it can be neglected, maksudnya dibiarkan lama, would be TB spine ke pyogenic?
TB subtle and chronic.
Yes, because the main difference between pyogenic and TB spine is the chronicity. Faham tak? Maksudnya you clerk the patient, dia tanya sakit ni dah berapa lama. So kalau TB, if you suspect TB spine, sakit dia mesti dah berapa tahun. If you suspect it's pyogenic spine, usually sakit dia dalam mungkin beberapa bulan. Because the chronicity is the main thing that differentiates between TB spine dengan pyogenic. Because TB spine is a very chronic type of infection, subacute, dia very subtle type of infection. That's why you boleh biar lama sampai form gibbous. Orang tak perasan pun. But in a pyogenic spine, it's different. The pain is very severe, mengganggu tidur malam, you ada chills, rigor, fever dan sebagainya. So this type of infection, this type of spine infection, the patient will come to see the doctor as early as possible. Dia lain dengan TB spine. So that is the main thing that when you clot, you have to differentiate. And when you suspect that it is a possible feature of infection, then you have to highlight this. The problem is a very chronic type of problem. And then dia ada history of exposure ke, ataupun dia ada presence of night sweat. And then dia ada apa lagi, dia ada possible history of chronic cough. All features that suggest to you that it is possible TB, and often the site in TB spine is more at the thoracic area. Okay, pyogenic spine can be anywhere, can be cervical, can be thoracic, can be lumbar, right? But often dekat cervical lah. Okay, so that's the main clinical difference that you will see, right? So I think because I wasn't part in the exam yang banyak orang kecundang dengan TB spine tu. But I think the one that made majority of the people fail at that one because they didn't even consider differential diagnosis of spine infection. Okay, so you just focus on one diagnosis. So macam aku cerita pada budak-budak group aku lah, when you come to orthopedics, trauma is very straightforward. You don't need to have a lot of differential diagnosis. Infection also is relatively straightforward. Maybe differential diagnosis in the sense of the severity of the infection, either diabetic foot, ataupun necrotizing fasciitis, ataupun cellulitis. But it's basically everything is infection, right? But when you come to elective orthopedics, which basically are the cases that you will see during your professional exam, maksudnya cases that comes in during the clinics. That's why you had to go to the clinics. When you come to these types of cases, you have to have multiple differential diagnoses that might be different from one another. Macam patient comes to you with joint pain, you have to have a list of differential diagnoses to rule out each. Tak bolehlah kata terus joint painnya terus OA. Tak boleh. You have to rule out either it is RA, ada tak, is it degenerative, is it inflammatory, is it crystal deposition disease, is it trauma, is it tumor. So all of that you have to rule out from your history and your presentation. Sama dengan back pain. not only focus on degenerative ataupun PID. I think waktu tu cuma dia focus on PID je. Tak consider langsung any other differential diagnosis. And actually patient is a TB spine. And the other features of TB spine, which was not elicited from that patient. So you have to open your mind, keep your mind open, jangan focus on one problem only when you get a case of elective orthopedics. All right. So you have to have a differential diagnosis. Back pain can be same, can be degenerative infection, can be spondylolisthesis, can be tumor. So all of this are the symptoms that you have to rule out. The common would be degenerative ataupun PID. Second would be infection. So kalau even the second topmost problem kau tak consider dalam you punya differential, susah sikit lah kita nak bagi pass, betul tak? Okay. So how do you manage a TB spine? Biasa tak sampai management lah, sebab itulah fail. Biasa kalau sampai management, pass lah insyaAllah. How do you manage? Last question, cepat. Aku nak pergi bengkel lagi ni. Okay, Aimi. Cepat Aimi. Aimi senyap je. Tak ada langsung nak offer jawapan. Aimi, cepat. How do you manage TB spine?
Investigate dulu ke?
Dah diagnose. Okay. Alang-alang kau tanya investigate. What's the goal? What's the gold standard of diagnosing TB spine? What investigative method is the gold standard?
MRI.
Dia bukanlah MRI per se, tapi the method lah, bukanlah investigative. What is the method, the gold standard method to diagnose TB spine?
CT guided biopsy spine for AFD.
Siapa jawab ni? Okay, yes, it is CT guided biopsy. Okay, so you guna CT, tapi you buat biopsy lah. So that's the gold standard. Alright. So Aimi, macam mana nak manage? So katalah you dah buat CT guided biopsy, it came back as TB spine. So kau nak buat apa?
Bagian NTTB.
NTTB. Okay. Kalau dia dah ada gibbous macam Aziz cakap, dah ada gibbous, is NTTB enough? Ya, dah ada severe deformity. Dah ada deformity lah. Bukanlah severe, dah ada deformity. Is NTTB enough?
Kena correct but deformity juga lah.
Ya ke? Okay, tak. The main management is still NTTB. Regardless, even if there is deformity, even in severe deformity, just giving NTTB is good enough. Maybe ada deformity, but that deformity tak mengganggu, tak ada masalah. We only have to do surgical intervention if the deformity is severe enough that one, ada neurological deficit. Second, it compromises patient's ability to breathe, because usually it involves the thorax. So if there is a severe kyphosis of the thorax, therefore your chest cavity will become smaller, betul tak? Because kau punya rib cage semua kat situ, so your chest cavity will become smaller, so your ability of there is a possibility that the lungs ability to expand becomes less. So patient tu tak effective sangat in breathing. So then you have to do deformity correction. Maksudnya you have to do a surgical correction. If there is no other accompanying symptoms, just some deformity but everything else is okay, NTTB is good enough. Okay? Tak payah buat apa-apa. Because they have done a very big study. One group just bagi NTTB for everything. Okay? One group give NTTB and surgical correction for everything. They have found that the one with surgical correction plus NTTB end up with more complications and significant complications. So they have opted for just giving NTTB. In only certain cases je yang they do surgical intervention. Okay? So that's NTTB, you should know lah. Dah belajar TB banyak kan, Prof Hao mesti dah ajar lah anti-TB dan sebagainya. It's the same. Cuma the duration tu longer because they involve bone. Kalau compare dengan compare dengan lung. Alright? Okay, aku rasa itu je kot untuk TB spine. I think the problem came because you didn't even consider infection. So that's why banyak orang kecundang lah waktu tu. Dan aku tahulah siapa yang kecundangkan. Aku tak ada waktu exam tu, so bukan aku lah. Anyways, so any questions? Tak ada? Cukup hari ni? Kita tanya Zaim dengan Aimi lah, cukup tak? Dia orang yang seru aku. Cukup tak?
Cukup, Mister.
Okay, aku rasa pun dah banyak dah cover, insyaAllah. Kalau kau dapat case non-union, insyaAllah boleh jawab kot, hopefully. Kalau nampak muka aku, tak semestinya non-union lah. Tapi kalau dapat muka aku, dapat case non-union, okay lah, insyaAllah. Alright. So, wish you guys good luck. Bila exam? Start exam? Sambah?
14.
To return kan? MCQ. Clinical?
Clinical lepas PR tu.
Lepas mengundi. 19 eh? 20.
21.
21. Yelah. Okay. So, good luck. InsyaAllah. Aku harap by bila? By 25 hari bulan semua yang ada kat sini kena panggil doktor lah. Boleh tambah doktor dekat ujung. Ujung depan. Boleh
Amin.
Tukar kat situ bukan MS lah. Dia jadi doktor lah. DR. InsyaAllah. Okay. Boleh insyaAllah. Alright. So, aku rasa cukup. Kita tamatkan dengan tasbih kifarah suratul As.